And now I call to the podium Mr. Javea. Alexandrou Τζαβέα is a consultant orthopedic surgeon at the Medical Interbalkan Center of Thessaloniki. He will talk to us regarding why hip arthroscopy failed.
So many things of this talk have been already said, so I will try to summarize a little bit some of them. No disclosures. We know that there are some unknown aspects of hip arthroscopy, although we have tremendous increase the last years. We don't clearly know why few patients are not doing well. And in this recent paper, in 53,000 patients, it was shown that there was a failure rate of 19%, so it's not very low. So what is fail after hip arthroscopy is the persistence of symptoms, inability to return to sports, symptoms deterioration, and the last stage proceeding to total hip arthroplasty. If we would like to summarize to categorize the causes of failure, there are four. It's the incorrect diagnosis we may make, the inadequate treatment, the iatrogenic causes, and also some patient-related factors. So starting with the first group, we know that the hip is a deep joint and there are many mimickers for hip pain, like discogenic, muscular pain, syndromes like deep gluteal syndrome or other types of extra-articular impingement. So before we take the patient for hip arthroscopy, we have to take a good history. And in my opinion, in most of them, we should do a hip block in order to prove that there is an intra-articular origin of pain. Another factor is the underestimation of osteoarthritis. Sometimes we focus on the FII and CAM, we see a good joint space, but we forget that this probably the onset of osteoarthritis, like this patient, 50-year-old patient, she had a hip arthroscopy. 1 year later, she had actually osteoarthritis and she went for total hip replacement. The underestimation of CAM, Mr. Pulchidis said before about the views. We have a long history of X-rays for the assessment of CAM lesion and the measurement of alpha angle. You can see here how different you can see a hip in the AP, frog lateral, and down view. And the down view looks to be the most reliable to measure the alpha angle. Same things apply to pincer lesion. We may underestimate it, especially if we don't use standardized X-rays. We should recognize the anterior and posterior limb, the crossover sign, and see also the classical sign, the classical measurements of the hip joint, the normal coxa profunda protrusio acetabuli. Also try to estimate if we have a global retroversion or a focal retroversion, and to assess also the borderline DDH. There are many hips that they have a positive crossover sign, but in reality, these hips are dysplastic. For the labrum, we should take a good MRI protocol. We have to speak with the radiologist and after discussion to decide whether there are strong indications for labral tear. And at last is the torsional pathology of the femur. This is a new issue that is discussed in the last years, and you will see in the next slides how this can affect the femoroacetabular impingement. So going to the next category is the inadequate treatment. As it was said before, you will see, if we see this paper from 2020, these are the indications for revision hip arthroscopy. This is a meta-analysis, and these are the procedures that have been done in these patients. If you see all the procedures, they deal with FAI and the labral tear. In this paper from 2021, for primary in high-level athletes, femoroplasty was the #1 procedure. And here again, from December 2021, femoral osteochondroplasty, pincer, and labral repair. Also, another fresh paper showed that the postoperative alpha angle is a predictor for return to sports. Another one showed the reason for revision was excess removal of FAI, residual FAI, and other issues like instability and chondral lesions. So actually, it seems that the main indications that send the patient for a hip arthroscopy, so that, which is the cam, the pincer, and the labral tear, are the factors that lead them to the failure. So it means that probably we don't do some things very well in these three indications. So the number one is the cam under resection. This is a patient that had a hip arthroscopy. You can see that FAI haven't, the cam lesion hasn't removed properly. And there are some tips, they have been said before, like to do dynamic, intraoperative dynamic examination, to a good preoperative planning, portal switch to see the cam from different angles, and of course, the continuous use of C-arm in the theater. And this is a patient that had nicely removed of the cam as seen on the done views. On the other hand, the ovary section is a catastrophic complication. We wouldn't like to have something like that. The ovary section may lead to AVN, stress fracture, and the absence of the sealing effect of the labrum. We can avoid it by being very careful to resect the bone very carefully and use some quantitative tricks like seeing our bear, which is usually 4.5 millimeters, and measure how deep we go with our instrument. And of course, the trend now is the computer navigation. There are some papers that show how accurate we could be if we could use one system that can guide us during the operation for the cam resection. And now for the pincer, same things apply there. The best thing is if we could measure the LCA angle also during the operation, and while removing the pincer, we have to see, eyeball this angle, and also see the crossover sign as it is changed during the operation. On the other hand, again, pincer over resection may be a dramatic complication because it may lead to microinstability or even in dislocation in a very rare cases. Pincer also is associated with the torsional abnormalities of the femur. So in the preoperative assessment, we have to measure also, if we can, the version of the femoral head. And now regarding the labrum, we now know that labral repair is the standard technique. This patient on the left, she had a hip arthroscopy with debridement, and we did labral repair. And so we go to the third group of complications, the iatrogenic complications that may lead to dissatisfaction of the patient. These are some complications that all we may had, especially in the first cases that we operated: labral injury, instrument breakage, and chondral injuries. This is very usual to happen, especially in very tight hips. And then it's the very hot issue that Ben Lund talked to us. It's the iatrogenic microinstability is the issue, and the discussion whether we have to always to repair the capsule or not. Although in the past there were some studies, like Ben Lund said, that there is no statistical difference between repair and non-repair. We know now that probably the standard technique is to repair all the capsules, but this is also an issue of debate. Of course, we should not forget the traction-related iatrogenic injuries that may also be dramatic and lead to dissatisfaction. And at last is the patient-related factors. There is a list of factors. Some of them we can understand them, some not. When you see these factors, you have to speak to the patient that we may not have a very good result after hip arthroscopy. So I would like just to show this saying of Philippon in this editorial, who said that we discuss that the under-resection of FAI and the CAM is the main problem. However, things are so much complicated that probably this is just one piece of the puzzle. So in conclusion, we know that hip arthroscopy is a promising technique. However, things are very complex. In some patients, there are many parameters that are unknown. There are some difficult patients that they are challenged for us, and we have continues to try and recognize the parameters of failure. However, at least we know that the FAI under-resection is the most frequent possible cause of failure. And thank you very much for your attention.